Hello and welcome to Health Matters on Channels Television. Thank you so much for joining us. I am Mary Alale Yusuf. The COVID-19 pandemic has brought unprecedented visibility to the work of field epidemiologists. But this visibility has not always resulted in understanding the importance of the field epidemiology, nor in the increased support needed to strengthen public health systems around the globe to better detect and respond to outbreaks. As the human and animal kingdoms come in proximity, the concept of One Health becomes more important, and the world is becoming a smaller place as diseases cross borders like never before. Field epidemiology is how epidemics and outbreaks are investigated and is used to implement measures to protect and improve the health of the public. How effective is surveillance of emergency outbreaks, and how quickly can emergency outbreaks be contained? My guest is speaking from our Abuja studio. She is field epidemiologist, antimicrobial resistance program manager, and assistant director, Nigeria Center for Disease Control. Dr. Abiodun Egwenu, you are welcome to the show.
Thank you for having me.
If you can hear me, let me just take off with the first question I have. We understand, of course, that field epidemiology involves investigating diseases and handling them as quickly as possible. The question I want to ask you is, what is the most challenging aspect of field epidemiology, in your opinion?
So field epidemiologists are epidemiologists, and the work of an epidemiologist is to first identify the cause of a health problem, identify those that are at risk, and then put in prevention or control measures. The key part of a field epidemiologist is that it must be on-site and the interventions have to be timely. So in a country where we still have few resources for health, timely intervention is sometimes an issue, not because of a lack of capacity, but usually as a lack of infrastructure at those sites where you need to respond rapidly. So this is one of the challenges of field epidemiology. And field epidemiology is a critical part of public health workforce in the global health security agenda, which we implement through the international health regulations, and Nigeria is one of the countries with an international health regulations focal point, that is at the NCDC. Field epidemiology is one of the 19 core capacities that countries need to have and need to assess regularly to see if they have this in place to prevent, detect, and respond to health issues, public health challenges on time.
How are the findings preserved for future generations? Bearing in mind that it could take 50 to 100 years for a disease to, recur. And if something that happened, say, 50, 100 years ago comes back, would scientists recognize it? Would they be able to respond promptly?
Yes, we have that capacity in Nigeria. In 2017, monkeypox, after over 40 years, re-emerged in Nigeria in 2017. And an epidemiologist detected this in Bielsa and was able to say, this is monkeypox, even though we've not seen it in a long while. And immediately it was detected. Nigeria CDC, who currently coordinates the Nigeria Field Epidemiology and Laboratory Training Program, actually worked closely with the Bielsa authorities, and we now included monkeypox in one of the notifiable diseases, and we have been reporting cases. So yes, because we do have a three-pronged approach, as you have mentioned, our field epidemiology program in Nigeria and globally is built on a One Health basis. So we look at human issues, animal issues, and environment, and the lab is at the center. So this laboratory capacity is what links this. And at the Nigeria CDC, we have the National Reference Lab, where field epidemiologists who have graduated, who have been trained, and those that are currently undergoing training are posted, and they support the work that we do by storing a lot of these isolates. And also we have a database where field epidemiologists also work on bulletins and reports that are archived on the social media websites for NCDC and other partners that collaborate with us, that is namely the Federal Ministry of Agriculture. So we do have this data already stored, and whatever goes on the web is actually something that is always there. So we have this stored in our archives, and we also publish this for the public to see.
You spoke of data just now. I know that NCDC has data, but you talk about not having the correct numbers sometimes. Sometimes I read about us not having reliable or complete data. How challenging is it for you, at the NCDC when it comes to having the correct data and collating the right data?
So at the national level, we have what we call the SOMAS app. This is an application that supports data collection from site. Usually you have a person from their home or from the community, they are ill. They might report to a health facility, or somebody in the community might notice something. And then this data now has to travel up to the national level. We do know that in 2001, there was a declaration, what we call the Abuja Declaration, that countries should provide 15% of their resources to health, which includes public health. But we have not yet reached that threshold in Nigeria. So this means that the capacity, and that's what I'm talking about, infrastructure, at the lower level, there's still a challenge. What we have done at the NCDC is we have 3-tiered program to the field epidemiology program, because epidemiology sits on data. You have to identify that there's a problem somewhere, there's a public health challenge somewhere, and you have to identify people that are at risk. Before you can do this, before you can describe a public health challenge in time, place, and person, you do need data. So in view of this, we have a 3-tiered approach to field epidemiology. We have the advanced field epidemiologists, we have those that are enrolled in the intermediate program, and we have the frontline. So this frontline field epidemiology, otherwise known as ITSIN now, is one of the ways by which we improve data collection. We train the local government disease surveillance and notification officers, and the state teams are trained through the intermediate or advanced field epidemiology to collect data properly, to transmit it through the identified channels, both to human health and also in the animal health sector. The Federal Ministry of Agriculture takes care of that. They have what they call the NADI system, and they report this data nationally. So we are not where we want to be, but we have really improved, and things are going better than it was before, because we have trained epidemiologists both at the front line and also at the middle levels.
How about everyday people, the man on the street? What can they do to make your job easier?
So the man on the street, if you see something, then you say something. Sometimes the man on the streets, they think they don't have this information, and that is why on the NCDC website, through interpersonal communications, through the state structures, through the LGH structures, we have what we call case definitions for diseases. There are things that you'll see and you say, oh, this is a condition that is notifiable. For example, monkeypox, we have the case definitions for measles and also for other forms of diseases. So if you do see something, you go to even the hospitals, we also put these case definitions there, and hospitals do notify the local government and the state, and they can also notify NCDC directly. So on our website, you will see info@ncdc.gov.ng. People can send information there, and this will be reviewed. Currently, we have over 1,000 frontline epidemiologists that are trained, and those that are in the advanced and intermediate, over 400. And they have been trained across all states in Nigeria. So that means at least in each state, you have at least one field epidemiologist, which is usually more than one, both at the front line and at the mid-levels. So we do have these persons who are also being trained to respond to conditions. When we had the Ebola outbreak, we deployed the field epidemiologist. During COVID-19, the field epidemiologists were very critical in running the emergency operation centers at the state and supporting the state teams to collate data. Even in the laboratories, we also trained epidemiologists. So we do have field epidemiologists all over the country. And we are working towards our target to ensure that we reach the global target for field epidemiology per population.
Don't you need more? How does one become a field epidemiologist?
So to become a field epidemiologist, we have 3 programs. One is the advanced field epidemiologist. We've trained 10 cohorts so far, and the 11th cohort is in training. We have already enrolled for the 12th cohort. For the cohort after the 12th cohort, there will be an advertisement. It is usually on the NCDC website, but it's also carried in national dailies. Anyone can apply, but there are certain criteria. So once the person meets the criteria, he or she comes for an exam, and the exam is competitive. For the intermediate epidemiology program also, there's usually an advert, but it's targeted at the states because we want the state teams to be trained also. And then we have the front line that is focused on the local governments. These are people that are working very closely. They live in the community. They listen. They work with community mobilizers and also community teams to actually detect diseases. So this is targeted primarily at the local government, and the states usually provide the names of these people, and we train them. And we have the advanced for 2 years. The training spans 2 years, for intermediate 9 months, and then for the frontline 3 months. So for the advanced and intermediate, there's usually a call. Once the call goes out, anyone can now come in and receive the training based on the fact that the individual has met the criteria. But there are also other universities that are providing this training as part of a master's program. We also encourage people to also receive such training to become epidemiologists.
Okay, you are an expert. Explain to us, how do you explain that a disease such as monkeypox was not such an emergency in Nigeria and suddenly became something of concern in other countries? What does that mean?
So, you know that diseases change. I always tell people that diseases are like humans. They want to survive. So they are also have some form of, let me say in quotes, intelligence. They change form to actually ensure that they survive. We also have the issue of globalization. In the past, if you wanted to go to another country, you would have to maybe travel by road, by boat. But as time passed, at the touch of a button, you can book a flight and go to another country. And then we have also urbanization. Human and animal interactions are increasing daily. We have other activities that we are moving into where animals live normally. So with that, we are coming into contact with new organisms that we would not have come into contact with. And then we also have vaccination. When a disease is eradicated, for example, let me use monkeypox. Monkeypox is closely related to the smallpox virus. When smallpox was eradicated in the world, the vaccination dropped. And with that, the coverage of persons that are immune to monkeypox also reduced. And we also are not sure of why the monkeypox, but the monkeypox virus might be changing from. This is one of the things that people are now looking at. And with change in lifestyle, food, immune system, with generations, with things that we interact with, the virus is changing form, humans are changing form. So when you get to a threshold where the virus can actually survive and can have sustained human-to-human transmission, then you can now start seeing outbreaks. So in the case of the monkeypox, there's a lot of global research going on. Why is it more in other countries? So we can't really say why. But what we know is that we need to protect ourselves. One of the ways to protect is to, once you see someone that meets the case definition of monkeypox, you report. We have the capacity in country to test. And when a person has monkeypox, we put in isolation measures, home isolation immediately, and monitor to ensure that transmission is reduced at that source.
So we're essentially restudying this thing.
Yes, so you have to, because, you know, that's what we call diseases emerging and re-emerging. Monkeypox, for example, is a re-emerging condition. We also have conditions that are re-emerging that we call drug-resistant infections. For example, antimicrobial resistance. This bacteria has been there. They've been treated with other antibiotics when Alexander Fleming found his antibiotic in 1945. But when it's now called a re-emerging condition because now the antibiotics or the drugs that were killing these microbes, the microbes no longer respond to this treatment. So with that, sometimes drug resistance can also make a condition change form. So we as epidemiologists, our role is to study these organisms, study human populations, and as the information changes, we also put in new measures to say this is the best measure. Let me give an example of COVID-19. When it first
Dr.
came on scene,
let me just pause you there. Let me pause you there because we need to go on a break. But when we come back, you can always pick up from where we left off. Welcome back. This is Health Matters on Channels Television, and we're talking about strengthening health surveillance with Dr. Abiodun Egwenu. You can call 0808-054-2233 for a question on this topic. You can also tweet at CTV_Mary A or send email moalale@channelstv.com. Dr. Egwenu, you were giving us an example of a re-emerging disease, a case like that. So go ahead.
Yes. So I was discussing COVID-19. When the COVID-19 pandemic started, a lot of people were wearing full PPEs, garbing themselves because people were not sure of how the condition was transmitted. Epidemiologists found out that it was a respiratory virus, and wearing a face mask, hand washing, physical distancing would actually reduce transmission. And then with time, epidemiologists also found vaccines. So I'm just showing that with the use of data, our approach to preventing transmission also changed. When the vaccination came up, we had only 2 doses. Over time, we noted that through data, through epidemiology, it was found out that the immunity wanes after a while, and that is why booster doses were introduced. So I'm just showing that these are examples of how the virus or infections can change form. As epidemiologists, we continue to track. We continue to see if our interventions work, measuring the condition versus the control or the prevention measures in place, and seeing if we need to change our strategy to reducing transmission or even eradicating an infection altogether.
Should we have continued to take smallpox vaccines?
So as at the time when the condition
Let me quickly pause you there. We'll go back to it in a minute. Let's take a call from John. Hello, John.
Okay, good afternoon.
Are you there, John?
Yes, good afternoon.
Well, then continue. Should we have continued with smallpox vaccines?
Okay, so for the smallpox vaccine, as at the time the vaccinations were stopped, the disease had been eradicated from the world. There was no need to continue to give a vaccination against something that does not exist. But the thing about the vaccination was that some vaccines have cross coverage, especially if there's another organism that is similar to this organism. So monkeypox is similar to smallpox, and that was why when those vaccinations were given, the emergence or the occurrence of monkeypox cases actually declined. Monkeypox itself is a self-limiting disease, meaning that majority of persons that have the infection will usually become better. But there are some people that might be infected and can progress to severe disease, especially if the person's immunity is compromised. So, and sometimes people do not know that their immunity is compromised. They don't know that, oh, I have comorbidity, might be hidden because they've not gone for checkup. And then with that, they have a progression of the disease and it becomes quite severe. So that is why for conditions like that, then we have to put in measures to reduce spread because we don't know how a person's immune system might take this infection as opposed to another person.
Hello, Akintuji. Are you on the line?
Yes.
What's your question?
So my question is, do we have epidemiological data for Nigeria with regards to most of the data we see are data that are being used from the foreign countries per se?
Okay. Thank you for that question. So yeah, that is a concern, Dr. Igwenu. We get a lot of data. We say it's WHO, or we say it's one other association or alliance. But how close are we to having our own data for all our own concerns?
So we do have data. In Nigeria, we have 41 to 42 notifiable diseases. That means these diseases are notifiable and reportable nationally. And that is what we call the Integrated Disease Surveillance Response. This document is on the NCDC website. Also on the NCDC website, we have the weekly epidemiologic report. Every week, we report on these notifiable diseases, especially the ones that are infectious. So if you go to the NCDC website, you will see national data provided through the LGAs, through the states, nationally. For COVID-19, aside from the weekly epidemiologic report, we have a whole website dedicated to COVID-19 that only shows data from Nigeria, not from any other place. So we do have data in country. And at the NCDC, our own job is to collate this data, present it to people, show where the infection might be circulating, and also provide prevention measures through our risk communication team on the field and also on the web.
This is some of the data I have quoted, so I can attest to that. But speaking about COVID-19, Dr. Tedros was saying that, you know, the end is near, because a little over a week ago, we had the lowest numbers globally. But I'm really interested in what this end looks like. Can you give us a peek?
So for Nigeria, the end for COVID-19 will be very near if everybody goes out for vaccination. In countries where the vaccination rates are over 70, the number of cases actually decline. In Nigeria, we are still around 20 to 30%.
Which isn't good enough.
And this is a call to all Nigerians, yes, which isn't good enough. So when we take vaccines, we are not just protecting ourselves, we are protecting people around us. We have
let me quickly jump in there, sorry, and take this call from Ada. Hello, Ada.
Hello, yes, Ada, calling from Jos, hello to your doctor.
Ada, are you still there?
Hello?
Yes, go ahead with your question.
I said to monkeypox or any other disease because the way we paid attention to COVID, because monkeypox and they are not democratic disease. What I mean is COVID was a democratic disease. It found its way to the seat of government. That is the problem. And as long as we continue to have medical tourism, nobody is going to fix our hospitals. God bless you. Let's not give up on this country. We shall be well.
Okay, I got part of that expression, not everything. But she spoke about a democratic disease, like, you know, maybe because it's not affecting other people, it's not being given attention. But following through from that, how much attention is actually given to diseases that occur just amongst us, that do not travel, that have not crossed borders to developed countries? How much attention do we give to those? Things like malaria.
So we do have programs that are focused on the malaria eradication from Nigeria and malaria elimination. Some of those, and when you talk about disease response and control, we should know that there are several prevention levels. One of the prevention levels that is kind of primary, we call the primary prevention, is through vaccination. But if you cannot vaccinate against a particular condition, then you screen. If you cannot fully screen, then you treat. If you don't have effective treatment, then you rehabilitate. So these are all levels of prevention. For malaria, one of the key ways by which we prevent malaria is through indoor residual spraying and also treatment. And that is why we have the protocols for treatment in Nigeria, where before you are given a malaria, before you are given antimalarials, you test so that you actually know the body. And now we have research going on. Recently, I read a paper where the vaccines against malaria, about 80% seroconversion rates. That means that is quite good. So this is one of the things that also Nigeria is included in, and then we are trying to see how to pilot, because pilots are going on in Africa and other countries. But once Nigeria is ready, then it's to pilot, and then once the vaccine is ineffective, it will also be one of the tools. And the goal for malaria is malaria eradication and
Thank you so much, Dr.
So elimination in Nigeria.
I'm sure we could go on and on,
yes.
but this, it will have to stop now. We're out of time. But thank you so much. And as usual, good job. Thanks for coming on the show.
Thank you. Thank you for having me. Thank you.
Thank you also for being with us today. Let's do it again next week. I'm Mary Alale Yusuf.